1. We are live.
Good evening, everyone. I am Dr. Abhijit Kale, and I am the coordinator for this West Zone Indian Orthopaedic Association CME. My co-coordinator is Dr. Ashish Phadnis. On the behalf of West Zone Indian Orthopaedic Association, I welcome you all for this second CME of the trauma series. And the topic for today is injuries around the hip joint. At the onset, may I call upon the Honorable President of the West Zone Indian Orthopaedic Association, Professor Dr. Ajit Shinde, to say a few words.
Thank you, Abhijit. Respected Chief Guest, Ioa President Dr. Ramesh Singh, Sir, Vice President Dr. Ram Chadda, and Honorary Secretary Dr. Naveen Thakkar, dignitaries and my team members of West Zone of Ioa. My mentor, Dr. G S Kulkarni, Sir, Dr. CJ Thakkar, Sir, President and Secretaries of Maharashtra and Gujarat Orthopaedic Association, Dr. Vasudev Gade Pune, Dr. Narayan Karne, Dr. Govind Purohit, and Dr. Kamlesh Dev, and all respected faculty members, good evening and welcome to second webinar of West Zone of Iowa. We have Karnataka Orthopaedic Association with us today as a guest chapter. Welcome President Professor Dr. Ashwini Kumar Sir and Secretary Dr. Bharat Raju, and I thank you for your support and participation in this CME. Also, I thank Pune Orthopedic Society for their active participation, President Dr. Chetan Pradhan and Secretary Dr. Sapnil Bise. We have already talked about injuries around knee joint. Today we are dealing with injuries around hip joint as said by Abhijit. Being a ball and socket joint, it is a very much mobile as well as stable with strong support of muscle and ligaments. Biomechanics of hip joint is precarious and is governed by joint reaction forces, abductor muscle force and body weight. While reconstructing injuries around hip, we must take care all of this into consideration and try to restore the anatomy. We have excellent panel to discuss the issue. I am sure this is going to be interesting discussion with our moderators, Dr. Chetan Pradhan and Dr. Dhaval Desai Sir, who are eminent surgeon and esteemed faculty with wide experience. And eminent surgeons from West Zone as well as Karnataka are going to present the interested cases for fruitful discussion. Dr. Ajit Kumar, Dr. Sharath KR, Dr. Uday Kumar, Dr. Jignesh Pandya, and Dr. Shankar. Thank you, Dr. Abhijit and Dr. Abhishek for well organizing and coordinating the session. And thanks to Team Ortho TV for their collaboration. Thank you, everyone, and all the best. I request President of Iowa, Honorable Professor Singh Sir, to say few words for guide us. Thank you very much.
Thank you. Good evening, everybody. I'll just wish to share my screen because I have been asked to talk about success with surgical and soft skills. And because that is our presidential theme for this year. When we are talking about technical skill, we all appreciate that these skills tend to improve with time. And there is a very well-established volume-outcome relationship. More is the experience, especially in the complex cases, better is the outcome with the experience, no doubt about it. But the question comes, are the technical skills enough in isolation? It has been seen in USA that every year 44,000 to 98,000 people die due to medical errors. And that's a very high figure. The similar observation has been in the Scottish audit also, where they found that out of all the problems which come up, technical error were just 4.3%. For more errors came from the poor decision making. This is what our own grievance committee this year, we started looking for what is the data in our hospitals. And this is one of the observations that we looked at all the complaints in one of the major hospitals. What were the reasons for the complaint? And what we found it out that 50% of the complaints were of inadequate and poor communication or a bad behavior from the doctor's side. Delay in treatment was complained by 28%, while error or complication were only 23% as a cause of the complaint. So primarily it is the poor communication and a bad behavior. This has also been seen that system errors out of the close malpractice claims in one of the analysis. System factors were error in 82%, but communication breakdown was reported in 24% of the malpractice claims. And what all it happens because we are lacking the teamwork within us, and especially in giving this data of the patient to the next person who is taking care of it. And this is what we call as a handoff. We are inadequately doing the handoff, and that brings the problem. So as far as GP is concerned, good medical practice demand that whenever we have the next person to be taking care of, it must share every information appropriately. And a good doctor does not simply mean a good clinician. He has to be a leader, because especially in a theater kind where as a surgeon we are dealing with, a full surgical team obeys the surgeon. And if he is distorted in his surgical directions, everything can go haywire. If he's comfortable, if he's in the right mood, the total team is likely to be very helpful. But if he's under stress, the leadership suffers and everybody gets into a problem in this situation. So leadership is a fundamental for a good, successful surgical practice, very well established. And it does not come to the end with the good leadership. We need to learn lifelong. I mean, we have examples here. Dr. Kulkarni is one of the best examples with us. Lifelong learning, keeping up to date. These are the integral foundations of ethical surgical practice. Around the world, many new things are happening. And definitely so many trials, so many research every day coming in. But what to read and what to believe on, we have to be very careful about selecting them. We need to define what is the rationale of clinical decision making. And we must allow the surgeon to consult, counsel, and consent the patients in a very well informed way. That way we can deal with in a proper sense. And during this, we must respect the autonomy of the patients. Patients tend to know by the quality of their interaction with the surgeon, who is a good surgeon, who is not a good surgeon. So this professionalism has to be there. So I had to conclude that surgical practice consists both to be successful technical and non-technical skills. We must remain evidence-based. We must remain in our lifelong learning. We must look for our outcomes. And we must have supportive institutional and health service, because we are not a pair of hands. We have to be a good team player who listens and communicates well with the patient and the colleagues and empowers all of them to reach their full potential. Thank you.
Thank you, Professor Singh, sir, for a wonderful message. I guess he himself has personified whatever he has spoken out. He is himself leading by example, whatever his words he has put down in the presentation. We are indeed grateful that he has come down and delivered such an important message on this stage. Next, we move on to Dr. Ashwini Kumar Singh, who is the president of Karnataka Orthopaedic Association. So may I call upon Dr. Ashwini Kumar Singh, Jamedar sir, to give his inaugural address at this CME.
Good evening, sir. At the outset, I thank the West Zone Orthopedic Association for coming up with a webinar on the injuries around the hip. Professor Singh, sir, Ioa President, Dr. Ajit Shinde, West Zone Ioa President, and Abhijit and Ashish. I congratulate all of you for organizing an excellent webinar around the injuries around the hip. And not only the webinar, as well as you are asking us, the Karnataka Orthopaedic Association, to be the guest thing. And not only this increases the bond between us, it will increase the interactive discussions between the two states and help us understanding better about the problems of our associations. That is the one thing. I congratulate again all the speakers and best wishes for all the one for this CME and webinar. Thank you all.
Thank you, sir, for your encouraging words. So we move over to the scientific part of the CME. And the first talk is by Professor Dr. CJ Thakkar, who is going to speak on the central dislocation of hip. And he has shared his presentation, and I will be sharing it from my side. In case there are any issues, please do let me know. Is my screen visible? Can you see my screen?
Yes, yes, sir.
Is the video audible and visible?
Audio is not yet visible, not heard still. Only the screen is. I think the audio is not heard, sir.
Okay, fine. I will put on the audio separately. Just a sec, I'm pausing the video.
Yeah.
To an untrained eye, all these X-rays.
I'm playing the video from the beginning.
Yeah.
Show commutative fracture of the acetabulum with central dislocation, a common radiology report. So what exactly one means by central dislocation? Central dislocation is the status or station of femoral head as seen in the AP view. It is important to visualize what intimate structures are visualized as pelvic brain, and iliac line, because when the station of the head is medial to these two landmarks, it appears as centrally dislocated in AP X-ray. The iliac and obturator views are of paramount importance to further clarify breach in the acetabular columns. This is a classic example of failed lateral traction to treat so-called central dislocation. What is needed here is the elevation of impacted medial root fragment supported with bone graft and proper internal stabilization, and then confirming that the joint is congruous in all the three views. Hence, the need to master understanding of three basic views and not just rely on 3D CT scan. Lateral traction may work only if with ligamentotexis, the columns also get reduced. In this example, the central dislocation is due to rare anterior wall fracture. Treated by anterior approach and internal fixation. In this example of low anterior column fracture with joint impaction and disruption of the quadric plane, which caused the central dislocation. Surgically, the impacted piece was elevated and bone grafted. The columns were stabilized with interfragmentary screw. The quadrilateral plate was buttressed using a lower and radius plate, and the iliopubic plate was used as a neutralization plate. As you can see, one could achieve full function after proper internal fixation. Another example where the head appears displaced centrally. This time it is due to posterior column taking with the quadrilateral plate. This was managed by posterior approach, interfragmentary screws, buttress, and neutralization plates. This is essentially a transverse fracture with associated posterior wall fracture fixed by posterior approach. An example of T-shaped fracture where the head appears to be displaced centrally, treated by combined anterior and posterior approaches, congruent joint in all three views. Fourth column fracture, which was fixed only by anterior approach to fix both the columns. And the final function. This is very interesting. Both column fracture, but look at the weight bearing dome, how it has rotated and completely displaced. This was treated by combined approaches to fix this complex injury. So, central dislocation is actually the status or station of the femoral head seen in the AP view. What is important is to analyze the structures of the intermediate bone that is displaced, resulting in central dislocation, taking an appropriate approach, and stabilizing it using interfragmentary screws, buttress plates, and neutralization plate.
Thank you. That was in short about the central fracture dislocation. I apologize for the poor video quality if it was any. Let me stop unsharing the screen. Yeah. In case there are any questions, since we have Professor Singh sir with us, are there any questions for this? Or else we will move on to our next talk, which is by Professor Dr. G S Kulkarni sir, and he's going to speak on the neck of the femur fractures, and will try to correlate the mechanical and the biological parameters of the neck of the femur fracture. Over to you, sir.
Oh yeah. Will share किया था? Hello.
Hello, sir. Yeah, you are audible and your PPT is also well visible.
Can you hear me now?
Yes, sir, we can hear you.
Okay. Right. The biology versus biomechanics of fracture neck of femur. This is a case-based presentation. I have presented this topic several times, and some of you might have heard me past. Now, Ioa has revolutionized the fixation of fracture. It was in 1960s to 70s. The pendulum was on the mechanic side. The fracture was opened. Fracture opened is not there, should not be there. Fracture is opened completely, and every fragment was isolated and fixed and compressed, and they called it absolute stability, and Muller and others were the chief workers in that. Then this had a lot of problems. We have done this. I have also witnessed many complications of absolute stability and opening the fracture and not respecting biology. The biology swung, the pendulum swung to the other end from 1980 to 2000. Minimally invasive surgery was introduced. The fracture was not opened, and it was a relative stability. Perrin and others were the chief persons who proposed this. However, during the last 2 decades, there are many workers and have been that both biology and mechanics are equally important. And Cody Kojima of Brazil in 2017 introduced a concept of absolute stability, in which there is both mechanics and biology, both are equally important. What happens if you use DHS plus derotation screw or 3 cancellous screws for fracture neck of femur? There is a shocking meta-analysis by Collins and others et al. In this last month, JOT, this is the meta-analysis. 492 patients were treated, selected, less than 50 years of age. 23% were non-union, 12% were avian, 15% had shortening more than 10 millimeters, 45% required revision surgery, and they used DHS and 3 cancellous screws in all these patients. Why DHS and 3 cancellous screw fail? Is it mechanical or biological failure? Now let us consider the mechanical aspect. Shearing force is the main cause. In our study, we have found that the shearing force is the main cause. Second, very important, is the poor reduction. Anatomical reduction is a must. Anatomical reduction increases the vascularity and stability. So it is both mechanical and biological. Poor choice of implant and placement, poor placement of implant. Sliding movement is another cause of failure. In biology, we have to consider osteoporosis because the implant holding capacity of the bone is very poor. And vascularity is very important. Vascularity is compromised, especially in Gordon 4 and Powell's 3 type. So shearing force and poor reduction, these I think are the main causes. If you take care of these two, then the majority of the fractures will unite. This is a very interesting case of a female, 38 years old, with fibrous dysplasia, pathological fracture a year back, and she was walking with a stick on this. Note the displacement pointed out, and this was treated with valgus osteotomy. And she came last month for backache, and we had an opportunity to take X-rays of the hip. And 12 years later, note the union, and there is no union, full function. In this case, we just have changed the biomechanics. We have not done any biology treatment, that is the bone grafting or any substitutes or vascular changes to increase the vascularity and all. Shearing force is an important cause of non-unionary BN. What is the evidence? The robust evidence is for non-union is, I'm sorry, this X-ray is not, okay. This patient, 36 years old, 1 year of non-union, he is a medical representative, 1 year of old non-union of fracture neck femur with lot of fibrous tissue, absorption and gap, sclerosis, still fracture united after valgus osteotomy, no AVN after 6 years of follow-up. How the fracture united? How the bed was revascularized? So we feel that the shearing forces converted to compressive forces, and that is the point where the fracture united. Compression increases the ratio of compressive forces upon shearing forces. If the compression is more than the shearing forces, the fracture unite. If the shearing forces are more than the compressive fractures, the fracture does not unite. See, the femur is the only bone which is cantilever, has a cantilever approach, and it has a tremendous forces because of the weight bearing and the ground reaction force. You can see this, the tremendous forces acting on the sliding of the screws is another cause. It causes collapse of the head and varus collapse. It hinders primary healing, and sliding movement always has a shearing element. All these lead to non-union. Reduction, as I have told you, is very important. And we have developed a technique which has helped me a lot in reduction of fracture and reduce the incidence of open reduction. This is a pre-reduction X-ray. What we do is we pass a sling around the proximal thigh and pull it laterally and distally so that this impacts the fragment. Note here there is a disimpaction, and then do internal longitudinal traction, internal rotation, and some adduction, abduction, and the fragment. There is a small fragment there which is seen, but this is anatomical reduction in both AP and lateral views. This is a very good method. Another method is you insert a hook in the trochanteric fossa and insert a Steinman pin in the head as a joystick and reduce the fragment. How do you assess the reduction? The Gordon's index and Loyal's curves are not so important, not so valuable, but the Heidukiewicz technique of assessment is very good. She has divided into excellent, good, fair, and poor. The excellent one is on the displacement in any direction and angulation. If the displacement is 0.2 millimeter and angulation 5 degrees, excellent reduction. If it is 2 to 5 millimeters and 5 to 10, good. And fair is 5 to 10 millimeters of displacement and 10 to 15 degrees of angulation. This the surgeon has to decide whether to accept or not on the table. Where more than 10 millimeters of displacement and angulation, one should not accept. New light on vascularity. Inferior retinacular artery protected in Wettbridge ligament, and inferior retinacular artery is 1.6 millimeters away from the cortex, while other retinacular arteries, superior, inferior, and posterior, are all adherent to the cortex. So it has been shown many papers that the inferior retinacular artery revascularizes the head of the neck of the femur. Fixation. We have classified the currently used implants, popularly used, is the uncontrolled sliding is DHS and 3 cancerous screws, whereas controlled sliding is Debussy-Synthesis fracture neck system, Smith and Nephew fracture conquest. We have developed a controlled DHS system and Targon FN. Absolute stability is proximal femoral locking plate, anterior-inferior plate. We have also developed a locking DHS and GSKT system. Others are fully threaded screws, Powell screws, and Philip Pow method. The controlled DHS, this is a male aged 42, had a motorbike from a fall, and we used the Debussy-Synthesis fracture neck system, which allows compression and controlled sliding. The sliding may be 5 millimeter, 10 millimeter, or 15 millimeters. In this patient, and this is a minimally invasive surgery. We used a 5 millimeter in this case, and you can notice there is a good reduction after 1.5 years. There is a shown no AVN at this stage, and fracture has united. When mobility stops, healing starts. This is the sliding, 5 millimeter sliding. We modified DHS into 2 types. Type 1, controlled sliding DHS, and type 2 is locking DHS. This is controlled DHS. You can see here, there is a, see the screw, how the moves, and this, the head of cortical head prevents the further sliding. Now, control sliding, these top screws are modified. This is a conventional top screw. Medium is 5 millimeters and 10 millimeters is the large. Now, conventional screw gives 10 millimeters sliding of the screw, and medium gives 5 millimeters, and this is 10 millimeters. 10 millimeter gives only 1 millimeter of movement, that is just a 1 millimeter. These are the 3 types of screws. And I'll show you one case. This is a female for 39-year displacement, combination controlled sliding by GSK control shell. Now, this is the one which is sliding, and you can see this is a fracture has united. Now, locking DHS, we have used locking screws. You first compress the fragment, remove the conventional screw, and then replace the locking screw. Now, this is a male age 30, good bone stock, no displacement, ideal for GSK locking. And this is the locking system that we have used, and the fracture is united. We'll go forward. This is the triangle system, which is gives absolute stability. This is another case which has given, see, all around there is a comminution, and there is 74 degrees bone stock. This was treated with a triangular system that I am talking about, and the fracture united nicely. This is another case, 70 degrees, and we have used now here valgus osteotomy for this case. This is another case, delayed presentation, and treated with valgus osteotomy and triangular system. This is an interesting case of a male age 32. He had no fracture. of the neck of femur, but this was treated in a wrong way. So he developed non-union of the shaft, and he had no fall, but the stress caused the fracture of the neck of femur. This was treated with a triangular system, and this united nicely. Climbed up and test go is normal. Our experience is 40 cases, follow-up for 4 to 40 months, 3 non-union, 7.5% due to technical faults and wrong selection, even in one case. But however, our follow-up should be more and more expected AVN. Now, take-home message is that biology and biomechanics are equally important. So we feel that we should not use simple DHS and 3 cancellous screws. If bone stock is good, you may use a GSK locking DHS or proximal femoral locking plate. If osteoporosis or comminution, use Depisynthesis FNS or GSK controlled DHS. Our system is cost effective. Both Depisynthesis and our systems have a controlled collapse, 5 millimeter, 10 millimeter, and 15 millimeters, and maybe both are equally effective. If Powell's type 3, delayed presentation or non-union, add valgus osteotomy. Thank you very much.
Thank you, Dr. Kulkarni sir, for a wonderful presentation. We'll take a question on this talk together with the other 2 talks. So let's move over to the 3rd talk of the session, which will be none other than by Dr. Dhaval Desai, who's the chairman of the AO Trauma India. And sir will be speaking on the proximal femoral fracture nailing. Over to you, sir.
Yeah, one second. Thank you, Abhijit, and thank you, West Zone Orthopedic Association. So, proximal femoral nailings is kind of the evolution for management of intertrochanteric and subtrochanteric fractures. However, this technique has its own challenges vis-a-vis failures, and what I'm going to show is ways to face challenging situations, especially in obese patients and in complex patients, to how to reduce and fix these fractures by a way that's different from what normally we're used to. So, as I say, there are many ways to do it, but the Americans say there's a my way and my way. But jokes apart, I think traditionally, and most of us are used to nailing with using the fracture table. But my experience says that it may be easier to nail some of these fractures without the fracture table, and this is what I'm going to share with you. Whatever you do, whatever the position, I think the key element of successful outcome is a good reduction that's maintained, and then use of implant that's adequate and appropriate for providing stability. Reduction remains the key issue, and I think getting a good reduction by the most easiest way or most less damaging way would remain the key in managing these fractures. So this is what I've been doing, and I prefer since the last about 3-4 years. I've not been using fracture tables for proximal femur fractures. I think the reduction is much easier. It's much helpful to do open reduction, and then in very obese patients, it's really easy to get access to the entry point. And we know that the entry point remains the key issue in getting the nail rightly positions. Okay. Use of wires wherever necessary, use of clamps, and that's the patient then went on to mobilize. Okay. So I'll give you 2 cases that are kind of to share. One very comminuted subtrochanteric fracture and another intertrochanteric fracture with extension into the subtrochanteric region. And I will share how I would manage these cases. Right. So I think surgeons have zone of comfort, and very often surgeons usually don't come out of zone of comfort. Okay. I think time in and time out, maybe with implants, maybe with the positioning or way you do things, surgeons usually don't give up the zone of comfort. Okay. So nailing in lateral position has particular advantage, especially in when you're very obese patient. This is definitely helpful. I think there are some easy tips and tricks, and one of everybody's mind or the key question is how do you image, and the imaging is much easier. And then specific situation, especially in subtrochanteric fracture, this has many advantages. And then there are some situations where you might be challenged to do this. Okay. So first and foremost thing is to image. And the key to imaging, I think before you start, you have to make sure that you can image. If you don't image, don't proceed. So this is the AP and this is the lateral CM of this very obese patient. Then the rest things of doing a medial entry is now everybody's known, and it's a known fact that we try to be on the medial side of the tip of the trochanter. And that's the lateral view of this patient on the lateral position. Okay. Another case is spiral subtrochanteric fracture. I think these fractures are much easier reduced in lateral, I feel. Ability to use a mini open reduction, percutaneous tools, and this is this fracture reduced by a percutaneous cerclage. And percutaneous doesn't mean not making an incision. I think in subtrochanteric fractures, I think there should be a low threshold to do a mini open, clamp it, or use the cerclage wire passer. And I think with these passers, it's important to be careful in order to see that the posterior septum is erased, and then you can get both the ends together. Otherwise, the risks of neural and vascular injuries is known and present. Okay, this fracture goes on to heal in its 4 to 6 months time. Or take this fracture. Now, this is where the muscle deforming forces are what would challenge you on, again, along with osteoporosis. Now, seeing this fracture now in AP in the lateral position, just by the positioning, it gets reduced, and then you go on to have a successful nailing. So some of the advantage of this is it takes away the deforming forces very easily. Whether you can do whatever you need to do, yes, you can do most things, almost everything well. So in this case, as we have seen that sometimes medializing the entry when you're not happy with the entry. So I think take your time to check your entry and ensure that the entry remains where it's supposed to be, or if not in the right position, make sure that it stays or it's deflected medially. Okay. And we know of the various maneuvers to do that. Finally, this gentleman had 2 fractures that were 2 weeks apart and treated by 2 different techniques and by 2 different position. Outcome probably similar with this. These were probably simpler fractures. So I think the comparison may not be appropriate. What's important in getting in successful outcome, I think, is the ability to reduce. So this is a high, this is a A3 fracture with sort of kind of a high fracture, transverse variety. I think getting a reduction or a provisional stabilization before proceeding is nailing could be. So this is one of the tricks, to use a 3.5 plate, and the 3.5 plate position posterolaterally has helped in holding onto the reduction while you do this. So this is one of the tricks that one could try in some situation, or the use of a cerclage wire. Okay. So again, this A3 fracture reduced very well in lateral position. I think one of the, this can't be described, but I think the valgus is restored very well with this. So the next staff angle is restoration is, I think, pretty better. And then you don't need to put in too much of traction. Okay. Another trip. So medialization of the shaft corrected with a bone bump under the, a bump under the proximal femur. That's the reduction. And then when you have vertical split in the genital trochanter, you can also reduce or do an open reduction of the vertical split with a cerclage wire. So these are some tips and tricks. Okay. Finally, goes on to heal. So I think there are certain advantages that have been described, including lesser risk of nerve palsy. I think the ease of starting point and the ability to do easy open reduction. It's safe and effective. Complications similar. Okay. In very obese patient, very easy or helpful to do reduction and maintain the reduction while you successfully nail this. Okay. Or let's take this subtrochanteric fracture. Rather complex subtrochanteric fracture. In position, reduced, clamped, and then clamp maintained till the nailing procedure is. So you also need tools. I think these fractures or these reductions or these nailings also need some good clever tools which you must invest and use, and the use of additional techniques like circlage wiring. Okay. And as I said, the circlage wiring has to be done with caution. Okay. I think it's one of the advantages, I think, is it's a technique that's reproducible and teachable. When your colleagues start doing it, then you must think that this technique is a good technique. Okay. Finally, let me share this case. This was a case post-COVID, 15-day obese patient spiral subtroch. This was, as I said, using the eraser for the posterior intramuscular septum, then using the percutaneous passer, checking that it's there and clamped well. I think you need to confirm that before you pass. And then sometimes, as I said, don't hesitate to use a clamp. And this is using a simpler clamp sometimes is what works or what is very helpful, especially in subtroch. So you can do a very kinder open reduction. Okay. And then, as I said, ensuring entry. So with some of the newer nailing devices, you have clever tools where you can change your entry without keeping the previous visor. And these are useful tips and tricks in order to optimize your entry. So don't start with a non-happy entry. Okay. And then standard nailing techniques. If you have radiolucent jigs that's very advantage, because then the proximal neck visualization becomes very easy. Everybody asks whether seeing the neck is easy, and I think seeing the neck is not difficult with lateral position nailing, as you showed with the images. Okay. This is the newer nail design where, because of the curvature, the distal part of the nail remains centralized, unlike in other designs where you might land up touching the anterior cortex. So these are advantages of some of the newer nails. Okay. That's the patient at 3 months at follow-up, that's healed, and that's him at outpatient. Okay. So I think we see a lot of these ladies with sufficient obesity, and I feel that the advantage of lateral position nailing is tremendous in that situation. It makes life much easier. As I've shown this is the reduction, entry, guide wire, and then the imaging with nailing. So finally, I think intertrochs or subtrochs, both of these, the key issue remains reduction. The positioning for this is very simple. You just flex the opposite hip to more than 90 degrees. Then the both hips don't overlap. Your normal AP becomes lateral, and the lateral becomes AP in the form of C-arm positioning. And then you can always turn 20, 30 degrees on both sides if you have challenges to proximal neck visualization after the jig is on. Okay. But reduction, entry, and I think then finally performing the nailing is the key outcome measures. Okay. Right. So finally, that complex subtrochanteric fracture reduced in lateral position, nailed, and now being mobilized. Okay. Finally, I think even with intertrochanteric fractures, I find that this position definitely offers you advantage in imaging is easier. I think the reduction is easier, and then the neck shaft angle restoration is adequately good, and the nailing procedure is then as one would do. That's our mobilized. Finally, thank you everybody.
Thank you, sir. So that was the presentation from the chairman of the Iowa Trauma India, Dr. Dhaval Desai, sir. Question and answers for all the previous 3 presentations. We will have it in a short while. Meanwhile, may I ask Dr. Ajit Kumar, sir, to share his case first, because since he's traveling and he's in the airport,
I think we should take his case,
and is scheduled to book, get into his next flight. He's a bit in a comfort zone right now. So should I start sharing your presentation?
I think Dr. Dhaval has it. If we can put it up.
So he's also. Yeah. I can do it.
Yeah.
Abhijit, do you do it?
Yes, sir. I will do it.
There may be some background noise because I'm in the airport lounge. Yeah.
No, it's wonderful, Ajit, but you made it.
Yes.
So this is essentially a case presentation of a Powell type 3 vertical shear fracture. We're just going to show our technique Am I audible?
Yes, yes. Yes, you are audible.
Just showing our way of dealing with this problematic fracture, because the failure rates world over is quite high in this particular fracture pattern. Although any type of fracture neck femur can be troublesome, it is more so in the type 3s Powell. So there are biomechanical studies which have said that DHS with a derotation screw is a good option in the conventional way. And there are other biomechanical studies which have said that proximal femoral locking plate is also good. Dr. Dawal also has, yeah, okay.
Yeah, it has come.
Yeah, okay. So this is a 32-year-old male following an RTA he presented to us. Of course, as you can see, there are problems in both the hips. The right hip, there is a vertical shear fracture of the neck of femur. Can the X-ray come up? Next slide, please. Can you click on for the next slide, Dr. Kale? Yeah. So the left hip, as you saw in the previous X-ray, was dislocated. There is an acetabular posterior wall fracture. So that was reduced. And once the reduction was done, this patient underwent a CT scan. And after the CT, we took him up for definitive fixation. So as you can see on the right hip, there is a fracture neck of femur, which is in a vertical sort of pattern. Can I have the next slide, doctor? Yeah, that is the CT showing you extensive comminution of the neck, and this makes it doubly worse. One is the vertical fracture pattern, and the second is the comminution that there is. So both are poor prognostic indicators for healing of this fracture and for subsequent complications. Next slide, please. That's the 3D CT showing the opposite acetabular fracture. So the next slide. So we took him up the same day, and we first, the patient was positioned on the fracture table in a scissor position because there was a dislocated hip on the right side. We didn't want to put it in a hemilithotomy position. So the leg was straight and abducted, the acetabular side, and the fracture neck was reduced as best as possible. And there was comminution of both the anterior and posterior cortices. So the options were next. Can you keep clicking on that? Yeah, DHS, FNS, next CCS, and also a locking plate is nowadays an option for this. So these in the cannulated screws and the proximal locking plate, they are more firm in their fixation, but the direction of your cannulated screws is not perpendicular to the fracture line. So these also fail subsequently, almost 18 to 28% failure rates in literature. Next slide, please. Yeah. Next slide. So this was the reduction that we achieved. Next. That's the lateral view, AP and lateral views. That's the first perpendicular screw going, like your Powell screw going in there. That's the lateral view of that perpendicular track. Next slide, please. Next one. So that's the second guide wire being passed for the Powell type of screw. Next. That's the lateral view as the guide wire is going in the second one. What you can appreciate is the corridor there in the lateral view for the DHS to go in. So that's the lateral view, and in the AP view, you can see that they're going perpendicular to the vertical fracture line. Next slide. So, and that is the guide wire going for the DHS. in between the two perpendicular screws. Next slide. So, and that's the DHS screw that's been passed and fixed distally with 3 screws. Next. So that's the final fixation on the right side. Some more valgus has been achieved there finally. But yeah, then subsequently we went on to fix the opposite acetabular fracture. So this is the final picture that we have. So this is the technique that we have been using for vertical type 3 Paul fractures. Depending on the CT based impression that we get, if there is no comminution, you can put 2 compression screws, both anterior and posterior. If there is comminution posteriorly, you put a position screw there, or you don't put a screw, but just put an anterior screw just to get the compression at that level. And if there is an anterior comminution, you put a posterior screw and an anterior position screw. So that's generally what we have been doing. And if there is comminution, both anteriorly and posteriorly, you put 2 position screws. You don't compress too much because you will shorten the neck. That's how we've been doing it for the past 3-4 years. Next slide, please. So this technique was published in the technical section of injury about 2 years ago. That was our presentation there. Next slide. So basically, take-home messages. In Powell type 3, we need to counteract the shearing forces. And you need, of course, like with any other fracture anywhere else, anatomic reduction is absolutely mandatory, more so in neck of femur fractures. Next slide. So obviously, this is a CT-based study and technique, and it is very useful to have a CT in these fractures because in plain X-rays, most often the comminution is missed, and in fact, sometimes even the verticality of the fracture may not be appreciated so much. Next slide. So, lag screw perpendicular to the fracture plane by counteracting shearing forces helps in healing of the fracture better than what would be with your cannulated screw systems. Thank you very much for your attention. Any questions, sir? Professor Kulkarni, is there any discussion on that?
Yeah. This is a very good method, Ajit, because you have, most important point is you have compressed the fragments by 2 Powell screws. That is a very, very important point. And your reduction was valgus. So this is a method, one of the options for this. However, we have done primary valgus osteotomy for these cases.
Yes, sir.
And we have reduced the verticality to about 40 degrees or so. And then our results are really 100% okay, 100%. And even surprisingly, the AVN is also reduced to this. I would like to ask you how many cases you have done and how many of them had Indian and how many of them had AVN and how many of them had a shortening. These are the 3 major complications of the neck femur.
Yes, sir. As regards shortening, we have not yet critically evaluated them, but AVNs we have not had any as of now. This is an ongoing study. It's we've been doing it for about 3.5-4 years now, and as far as I can remember, the first 20 cases or so that we evaluated. Of course, this is a short-term evaluation. We have not had any AVNs, sir, but we need to look at critically about the shortening. Yes, even in some of the cases that I have presented in my talk recently, a couple of cases there was a shortening of the neck in spite of the Powell screws. So that we need to critically assess whether we had put 2 position screws or just 1, or what was the real, what was the difference in our technique. For that, we need big numbers. So that part we have not yet come into. But as regards AVN, at the moment, we have not had any, sir.
Yeah. I would like to have a discussion amongst the panelists. 2 things that are very, very important from fracture neck point of view is how the fracture unites. whether it is by a compression method or whether it is a relative method, relative with absolute stability and relative stability. That is now question number one. And how the head gets vascularized. These are the two very, very important questions. If these two questions are answered, the riddle of fracture neck femur is solved. So I would like to have your opinion on how the fracture unites. Is it compression method or is it a relative method?
The cannulated screws also do allow some amount of because subsequently also there is a little bit of shortening that happens. So it's probably relative stability there. But in this particular fracture pattern, I think you need absolute stability. But the problem is the comminution is one issue that may be a problem there where to achieve compression, sir.
I have shown you a case in which there was severe comminution.
Yes.
Anteriorly, posteriorly. And we compressed them. And all these fragments act as bone graft because they are a cancellous bone. So my view at this stage is, of course, it has to be proved and very controversial that it is a compression method and absolute stability is very important in this case. In fracture. That is my view, but it has to be proved because there is a lot of opposition for absolute stability in fracture neck femur. And any idea about how the vascularity is? Yeah, you can have comments. Yes.
No, I was just about to ask you. Earlier, people were doing angle blade plates, sir. So there is not much of compression that you get, but still the excellent results were achieved in those days. So how do we explain that, sir?
No. What do you mean by excellent? Otherwise, everybody would have continued that. Nobody is now doing almost anywhere in the world. So I don't think that excellent result needs to be defined.
Okay. That I think probably because of the difficulty in the technique, that is the reason. It is like cemented hips going out and uncemented hips being popular, sir.
That's true. Yeah, but...
Kulkarni sir, one question.
Yeah.
So why are we saying about relative stability in fracture neck femur? Because we never see callus in fracture neck femurs.
Yeah, that's the reason why.
Therefore, what we are shortening and all that we get is because it settles, the cancellous bone will settle to its, without contact, the cancellous bone won't heal. And I think because there is sort of, the loss of cancellous bone in that area of fracture, that's why the shortening probably happens. So there is no question of, I think, relative stability I think we are confusing. There should not be relative stability in fracture neck femurs.
Yeah, this has to be settled. Of course, I am not 100% sure that, but I at this stage feel that absolute stability is necessary because any movement of at the neck of the femur, whether it is a sliding movement, the movement has an element of shearing force, and the shearing force is probably the cause of non-union. Secondly, when there is movement, there is no vascular ingrowth from the distal fragment, which is also one of the reasons why vascularity of the head is increased. So the problem of sliding movement, whether it is required or not, is really a big question. It's controversial. I am of the opinion that sliding is the cause of non-union and therefore it is not necessary. But whole world is allowing sliding.
So then the question comes is, in all these Philipov method and other methods, is the neck shortening zero or it's like less than the sliding moment?
So even these Philipov's method or whatever Ajit has shown nicely, there is a compression. He has compressed and made it valgus. So he has changed the mechanics from valgus reduction is very, very important. valgus reduction or even a valgus osteotomy is very important. So I think that is the reason why we should have.
So I think we have to wait for the result to be solved.
Biomechanics is more important here than biology.
Sure, sir. Thank you, sir. Thank you.
Any more questions for the first three presentation that we had, and also the case that was just presented? Sir,
Sir.
I have one question to Dr. Dhaval Desai, sir.
Ji, boliye.
Your presentation was wonderful, but AO has been teaching us that there are two prerequisites for proximal femoral nailing. The first prerequisite is to have a C-arm, and the second is to have a fracture table. Now, do we go away from it?
Who's going away from it? We are doing the same thing. We are using a CM, and the fracture table is not a prerequisite. I know where is it?
It's a relatively indicated.
I think so. It's, as I said, it's the zone of comfort, no?
Yeah.
So I feel if you have a very obese patient, I think you would be much more comfortable in doing it in lateral, because I think the two prerequisites, getting the right entry, getting a reduction. If that life is easier in by doing something alternate, I feel then you should consider that.
Very true.
So lot of people are moving over to lateral position for subtrochanteric fractures now. I think intertrochanteric, probably Chetan is around.
No, sir, he is not around.
Chetan will support probably, because he's the one who
uses
that.
We have been doing subtrochanteric fractures in the lateral position as well as in the supine position.
You can do both. I'm not saying you cannot. It's yours. You think it's a personal choice, but I find this is easier.
It is much easier. Yes.
I have not nailed any proximal femur on a fracture table in the last 4 years.
Yeah.
So point well taken. So the second query is there any difficulty in getting the lateral X-ray in proximal femoral nailing in a lateral position?
So honest answer. The first 2 or 3 cases, when I started, I abandoned because the radiographer couldn't show me a lateral. After that, the lateral has not been an issue. As I showed you in the example, even with the most obese patient, you can get it.
Yeah.
I think there are ways to do it. So you get a 90-degree angle between both the hips, and then you trace it from the shaft to the top. Don't come from the other way around. Yeah. Then usually you should be oriented yourself well.
Any more questions?
I would like to ask Dhawan, when there is a coronal split in the intertrochanteric fracture, how do you treat it?
Sir, so 2 things. You can use a tenaculum clamp to hold it, but I think better off would be to open and put in a circlage and get it reduced. Otherwise, the wire will keep on coming laterally, and then you will have a lateral entry for that. So that one of the example I showed, that was the technical problem, that the wire, once it was medial, it was shifting lateral, and then I thought it was the coronal split that was taking the wire away. So I think clamp or wire, I think wire better.
What we do is we put 1 or 2 lag screws percutaneously from anterior to posterior and compress the fragment. It's a coronal split. So that
we can do that, but usually those fragments are too crumbly to try a lag screw. If it works for nothing like that. Nothing like that, sir.
No, I agree. But passing a circular wire at the very proximal trochanter is not as easy as in the shaft. I would like to ask another question. When there is a lateral shattering of the lateral wall, how do you do this?
So I think those ones...
Complete shattering of the lateral wall is completely shattered and into multiple pieces.
Maybe then the nail is not a good option there, sir. Maybe a blade plate is a better option, perhaps.
No, what we do is we put nail and a plate combination, and that gives a really good help.
So
nail
my question to that would be, sir, like this. So if there is a wall deficiency, then should you put in a plate before you nail? Which is what I think about. I haven't tried that, but I'm just wondering.
No. First pass the nail and then pass the plate. Of course, you have to open this and reduce each fragment manually and then pass the nail. and large fragments can be lagged with lag screws. So, but that really gives a good result. So, the nail with plate combination is a very stable fixation.
So उसमें सर मुझे ऐसा लगता है कि we should have a subset of A33 to compare where you put in a plate and you didn't put in a plate, and then maybe we'll get the right answer, perhaps. But that's an interesting thought.
Yeah, since we have Professor Sen with us and Dr. CJT is not around, sir is not around. Sen sir, can you take a question on that central fracture dislocation, sir? In the central fracture dislocation, the quadrilateral plate is invariably involved. It's fractured.
Yes.
So what is the approach, your approach of choice to fix the quadrilateral plate? The Stopaz approach or the ilioinguinal approach?
With the change in the perception of the people and the ease of accessing on the medial side of the quadrilateral plate, the consensus world over is now to shift over to AIP or so-called Stopaz approach, because in most cases, if we have to access ilioinguinal, does not give the face. If you want to buttress, if you want to put a plate on the medial side, ilioinguinal does not permit it, and only the Stopaz or AIP approach permits it. So biomechanically, to support the medial wall, AIP is the option. And what has happened in the recent time, world over, whatever the new instruments are coming into making, they are all for AIP approach now, none for the ilioinguinal approach. It does not mean ilioinguinal approach is never to be used, because there are conditions where AIP cannot be done, just like a repeated injury or just like a previous cesarean section or a hernia surgery, where we will have to fall back to ilioinguinal approach. But definitely consensus, the reports, the literature, everything has shifted to AIP and combined with the lateral window, which is extended to a iliofemoral approach. So it's a combination of an iliofemoral plus AIP, which can solve most of the problem which ilioinguinal used to be used for.
Sensor, what about new plate designs that especially we are involved with, and the other?
Yes. So there has been about, I was looking for a literature world over, there are about 40 patents which have been filed for plates around acetabulum, and at least 14 are for the quadrilateral plate. Most of the designs are the same, that there will be a plate over the surface and there will be a plate either on the medial side of the surface plate. So medial side plates take a edge over to the surface, and surface plates give a shelf on the medial side of it. They are primarily to be fixed up. And the striker had the same design which has been used world over, and Indian copies have been made for the striker. Now Synthesis is also coming up with the almost similar design, but with a little more kind of an access into the fixation. So this is supposed to be the standard design world over. That is, there is a suprapectineal plate with its attachment down there towards the quadrilateral plate.
So which is a better approach to use this plate, the striker plate? The ilioinguinal approach or the Stopaz approach?
Stopaz approach is right now the standard approach. Though this has been designed, but Saji himself, who designed this plate, is only doing AIP or a Stopaz approach only.
Abhijit.
Yes, sir.
I like to ask one question to Dr. Dhawal Desai, sir.
Yeah, yes, Shinde, sir, please go ahead.
Go ahead, sir.
Sir, it is regarding the comminuted subtrochanteric fracture.
Yes, sir.
How you are maintaining traction without fracture table? Because this type of surgery, I feel, easier to do in lateral position on fracture table. This is one question.
Okay.
Secondly, once you are applying that cerclage wire, when you are tightening that after passing the nail, because if we tight prior to passing the nail, they will come two together and obstruct the reduction. What is your experience?
Sir, so I think that wire is a reduction tool. It doesn't have to be too tight around the fragments. I think if it's a little flexible, probably it would be better to guide your reamers and nail. You can also take it out once you pass the nail. So I think the role for the guide wire once the nail is through is still questionable. I think there's not much need for traction for subtrochanteric fracture. Somehow I find that once you got the reduction and the length, unlike a shaft of femur, the story would be different. Okay, so there lateral traction. I have some of my colleagues who use a lateral traction, but I really have not felt the need or the urge for doing that. So I think that in subtrochanteric, once you, and I think, as I said before, that I think we should have a low threshold to put in a clamp. Very low threshold to put in a clamp in subtrochanteric. And placing a clamp is much easier. You're probably using the same incision a little more longer for your blade or screw insertion. The same incision track is one you will use for putting your clamp. So very low threshold to clamp it. Regarding, so I think I would pass it before before I start my even my guide wire insertion or this thing. I will pass in the circulars before, because it's my reduction tool. Usually one suffices, but sometimes you would be a guide. Sometimes in those long spiral ones, you might need to put in either 2 clamps or 1 clamp and a wire. So either possibility is there, depending on how you find it on table.
Thank you, sir.
Thank you.
Any more questions? So one question to Dr. Kulkarni, sir, GSK, sir. Sir, you must have seen almost 6 to 7 decades of fracture neck of femur fixation.
Yeah.
Right from AM pins to SP nail to Givet's nail to the present era of FNS, femoral neck system.
Yeah.
Do you think that femoral neck system will be a final solution, or you see some more evolution to come?
No, I don't think so. As I have told you, that sliding, it allows sliding 5 millimeter, 10 millimeter, and 15 millimeters. But the results of this system is much superior to the simple DHS or 3 cancellous screws. I personally feel that 3 cancellous screws and DHS must be stopped doing. You must do something more than that. Either pass a Powell screw as Ajit has shown, or like a controlled DHS by Synthesis or by Smith and Nephew. One of these should be done. So the future is probably there are between 2. Is there a controlled collapse or no collapse at all? These 2 things are going to be, these are the 2 things that are to be settled in future. The future of is a controlled collapse or controlled sliding or no sliding by locking screws, locking plate, or locking DHS that I have shown. So one of these 2, either should be a no sliding or controlled sliding.
Sir, question to Kulkarni, sir.
Yeah, sorry, so please continue.
Sir,
yes,
can
sir.
I ask question to Kulkarni, sir?
Yeah, yes.
Sir, what is the difference between 3 cancellous screws and 4 cancellous screws? Do you believe 4 cancellous screws is better than 3 cancellous screws?
No, I don't think there is a need for 4th cancellous screw. Sometimes if there is a comminution and if there is a big bone, you can use 4th screw. But as I have told you, the cancellous screw is now not used. Even the present JOT, last month's JOT, has shown that if you read that, that's a very good article to read. You must read that. In that, they have shown that DHS is better, because America was using 3 cancellous screw for a long time. It was very popular. Now, currently, even there, the trend is to do DHS, more DHS derotation screw than 3 or 4 cancellous screws. I think you should abandon 3 cancellous screws at all, and you start doing DHS derotation screw or Synthesis.
Okay, sir. Thank you, sir.
Sir, one just in question regarding the locked and the non-locked, the stoppable DHS you have shown. So what is the plus from using a locking screw versus a non-locking screw in that control DHS you're showing? I was just interested to understand that.
my view of fracture neck femur is no sliding is required.
Okay.
Compress the fragments on the intraoperatively and no more collapse or no more sliding in the post-operative period. That is my view. And I have done about 60 cases now, and we are studying this and will be coming out after 1 year so that we'll have a thing. So sliding is given because of two things. One is there is comminution, or if there is a fracture absorption, which produces a gap. So that is why it is given. But it is not necessary. That's what I feel. Once you do compression, it is not necessary. Because when you do compression at the humerus, do you do any, there is no, it's not allowed any movement. The same thing applies to fracture neck femur. You compress it and it will unite.
Okay.
See, their example is that the valgus osteotomy for non-union of 1 year, 1.5 years, you must have done a lot of cases. The results are really very good. So what happens there is it is a compression. When the compression occurs, the naturally compression occurs due to weight. So in a valgus osteotomy, there is a compression and the compression is maintained. And that is the reason why that is the reason why I feel that compression is very, very important during the surgery and during the post-operative period.
Thank you, sir.
Can I just ask another clarification, sir?
Yeah, please go ahead, sir. Please go ahead.
No, it's just about the compression that you're talking about. But in the locked plates in the proximal femur, the anatomical plates, there is no compression. The locking screws are all position screws now, sir. So how do they achieve good? Biomechanically, these are supposed to be doing very well. But in vitro, in vivo, I'm not sure. How can we explain that, sir?
You're asking me?
Yes, sir.
So, see, if you see the proximal locking screws, they have all done compression first. And then they have removed the compression screws, lag screws, and then inserted the compression screws. Of course, the results by Burkiss in 2012, he produced 18 cases and produced a paper, very drastic complications of proximal femoral plate. Since then, the world was very much, that was a very good paper, and that's why the whole world was abandoned doing any locking compression plate. But recently, there are 4 papers from China which have done a large number of proximal femoral locking plate using again compression first, then you lock it.
Okay.
And they have created good results.
Okay, sir. Thank you.
Since we have Dr. Dhaval Desai sir with us, sir, does the AO still support the philosophy of proximal femoral plating, or has it withdrawn the plate?
I think it's less heard of, as I would say. I'm not hearing it much about it.
Yeah. Thank you, sir. So we'll move over to the next case. May I ask Dr. Dhaval Desai sir to moderate this session, and also Dr. GSK sir to join him as a moderator. Our next case is by Professor Dr. Sharath KR. Over to Dr. Sharath.
Thank you, sir, for involving me in this. I will be presenting a case of fracture neck femur with the posterior wall of the acetabulum. There was a displaced fracture neck femur posteriorly, and comminution in the neck and the posterior wall fracture comminuted acetabulum. So I had planned fixation for the neck and also for the fixation for the acetabulum, but I found comminution too much in the fracture neck, and I decided to do posterior wall fixation and total hip replacement simultaneously. I fixed the wall with the recon plates and spring plates, and Simultaneously did total hip replacement. So I followed this for 5 years. Is doing good. So just wanted to present this case.
Can you go back to the first X-ray?
Yes, sir.
Oh, we have a, okay.
He is 26 years old. Eh?
No, sir. He was 49 years old. Now he is 55 years old. Yeah, 5 years. Yes.
Okay.
So Professor Sharad, these injuries are per se, I think, bad injuries. So I don't, sensor is there?
Sir.
Sensor is there? No.
No, sir.
Okay.
He is
So,
not there.
I mean, just if you were to fix this, what would you kind of take the sequence of fixing, or how would you kind of?
Yeah, we have. Can I answer this question?
Yes, sir.
See, we had two cases like this, and we of course reduced the fracture and put the posterior wall was reconstructed, the pelvis was reconstructed, and we did a fixation with DHS and cancellous screw and added a valgus position of the head. In one case, we did a valgus position of the head, and in the second case, we did valgus osteotomy. Both united. One of them had a AVN after a long time, so that then he was converted into total hip replacement.
Sir, the one doubt was, whenever we do direct total hip replacement with a posterior wall fracture, sometimes with the healing of the cancellous bone, the collapse of the bone happens and the cup loosening may happen.
Yeah.
So that is the one thing which, what is the experience of senior faculty members with that, sir?
That is the reason why I feel that the posterior wall reconstruction should be done, and reconstruction of back fracture should be fixed. And then at a later stage, probably if the fracture has not united or if there is a AVN, then you can go ahead with the replacement.
Okay, sir.
I mean, it's dislocation, neck, femur, and this thing. So this is a very high risk of
high risk of AVN.
Cases that I have seen or people have presented follow-up. Sir, if sir is saying that they have become AVN or arthritic late, then that's really good, because you really saved a few years for the patient, I think. So it may be worth taking the chance to fix it and bite the bullet. I mean, these are destinally, but you at least have saved one bridge to cross little later on, I think.
Yeah.
Yes, sir. Yes, sir.
That's right.
Okay, sir. Thank you, sir.
Thank you. But if the sequence that you have to follow, would you follow? I mean, you do the neck first, in out, dislocated, reduce, and then you would put the acetabulum?
Sir, but how to reduce the neck if it was this thing? So you close reduction of the neck and then turn him lateral and put the acetabulum.
No, I think everything you have to do in one position only.
Yes, sir. That's the thing. Maybe we have to do open only. But when we open posteriorly, we will jeopardize the vascularity. So that is the problem.
The vascularity is almost gone now, no? With this much displacement on.
So dislocated.
Yes, sir.
Yeah, when it is dislocated, vascularity is gone. You have to, I think you have to do first pelvis, and at the same time your head is in your hand. You can reduce it and fix it.
Yes,
and
sir.
wait for the results. And he is likely to go into non-union or AVN. So he needs a replacement in shortly or in a future time.
One question: does anyone have a experience of using augments for reconstruction of the acetabulum in a primary situation?
For acetabulum fractures?
Yeah, for acetabulum fractures.
No, sir. No. It is not required. We have to put the bone grafting and probably impaction of the bone graft at the compressed area. That is, I think, is sufficient than augments probably.
Right.
Thank you, sir.
Fine, sir. Can we move over to the next case?
Yes, sir.
Yeah. So the next case will be presented by Dr. Uday Kumar. So can you share your screen?
Can you see the screen?
Yes.
Yes,
You
sir.
can see the screen?
Yeah.
Only I'll just make it. Anyway, I thank the West Zone for giving us this opportunity to. Can you see my screen? Yeah.
Yes, sir.
Yeah. Okay. This is a 36-year-old male patient who was operated in 2015 in another hospital. And this was the X-rays which he came with. No other previous X-rays are available. This was probably around 3 months post-surgery. Can I proceed, sir?
Yeah.
He had a problem then?
No, he had no problem. 2015, he had absolutely no problem.
Okay.
He was walking about with this this thing, and
The comments on this X-ray,
yes, sir.
that this is probably there is a subtrochante fracture there,
Yes, sir.
and this is 31.
He's 36 years old.
No. I'm talking about the subtrochante fracture, which is also therefore it is very, very unstable fracture. There are tremendous forces around there. So this is likely to go into non-union and breakage of the implant.
Yes. So he was walking about with this for about 4 years. And then he came to us in July 2019 with pain in the hip and not able to walk. So this was the X-ray when he came to us, as you had, as Professor S. Kulkarni has predicted. There is a break of the nail. So this was the problem. He had a non-union subtrochanteric fracture.
Yeah.
The nail is broken and the hip is in varus.
Yes.
Do you see anything else, sir?
Yeah. What if we have similar cases like this, several cases, what we have done is we have removed the implant and put a longer nail than this up to the end, longer nail, and an extra plate anteriorly or laterally, shingling of the fragment and bone grafting. An extra plate and a nail and a plate.
Yeah.
And bone grafting.
Sir, in this case, we just traced the proximal screw. We found that even this also is not in alignment. So we suspected that the proximal screw is also broken.
Yeah.
Here. So this was the problem. He was a 36-year-old, 4-year-old non-union. He has a broken nail, a broken proximal screw, and varus of the proximal femur. Sir, as you have described, how much of varus can you correct with a long nail in a 4-year-old non-union?
You have to correct the varus. You can even
with
do
an osteotomy.
Yeah, osteotomy also. You can do a wedge osteotomy at the fracture site and do a valgus correction. Valgus correction is very, very important.
Yes. So we tried a little different technique. I would like to just show our experience with that.
Yeah.
So first is this proximal screw. We removed the distal screw. We removed after that, the proximal screw was locked into the proximal part of the nail.
Oh.
So the proximal part of the nail, we had difficulty in removing that. So then what we did is we took a Steinman pin and gently tapped it into the into the head to unlock it. And we decided to, since we could not remove that, we decided to leave that broken proximal screw there only.
Mhm.
Once we freed it there, then we were able to remove the proximal part of the nail.
Yeah.
And the distal part, we used a reverse threaded extractor and removed the distal part of the nail. So this was the problem when we were going to remove the implant. And following that, what we did was, this was the removal of that. So if you see, this is we used the reverse threaded extractor to remove the distal part. We removed the proximal part. And we did the freshening of the fracture site. We did the shingling. And then we did a little different procedure. We used a proximal femoral locking plate to correct the varus.
Mhm.
So what we had done was we first put the proximal plate and fixed it with, this was the broken part of the screw that we left behind there. We fixed it with two screws here
Mhm.
and let it fix into the head. And then once we brought the plate down into the shaft, the varus got collected.
Yeah.
And we got a reasonably good valgus correction.
Yeah.
And following that, we used a Muller tension device to compress the fracture
Mhm. Very
and also bone grafted it.
Yeah.
And then, as you suggested, we put a anterior plate
Yeah.
in front of the femur to prevent whatever rotational element was going on.
Yeah.
So any comments on this, sir?
I think it should unite because you have
Yes,
done
sir.
everything nicely.
Yes,
But the results of proximal femoral
exactly, sir.
locking
Exactly.
plate
Yes, sir.
are
Yes,
not so good.
Yes, sir.
So this becomes a too stiff a implant
Yes, sir.
and likely to break. But as
Yes.
you have done dual plating, bone grafting you have done?
Yes, sir. Bone grafting done, shingling done, freshening of the fracture done.
Yeah, it has a chance of union, but
Yes, sir.
as I have told you, this is too
Can-
stiff implant because you have used 437 screws distally.
Exactly, sir.
Yeah, and optimally. So this may be a too stiff an implant
Yes, sir.
and may fail.
Maybe. Yes, sir. So this was at 3 months post-op, and he has been on a walker walking with a little gradually increasing the weight bearing. This is at 1 year post-op. And now we have seen him up to 4-5 years. He has no pain. He's walking comfortably.
Very good.
Until about 5-6 years now, no problem is there.
Very good.
This is the results of the patient.
Yeah.
And he's walking about comfortably.
Very good.
The only reason I put up this was our experience with, would you have tried a blade plate in this case?
No, I have not tried.
Huh? No, I mean, would it be a good option? But only thing was this broken screw was there inside. We'll have to go and remove that to put a blade plate.
Yeah.
So our experience with a blade plate is not so much in our part of Bangalore here.
Mhm.
But as you suggested, the other option would have been to put a long nail, correct the varus, and then go in with this. This is a little different type of technique which we did. And so far we have been successful. We have done about 5 to 6 cases in this method. Till
In
now we are doing
all
quite.
cases, you have put dual plates?
Yes, sir, all cases we have put dual.
Yeah.
All the cases.
I think.
All non-union subtroch we have put a dual.
Yeah. Very good.
So this was the, if there are any questions I can.
No, very well done.
Yes, sir.
So my question is, should we use the anterior blade first or not?
No, usually we finish the primary fixation either with a long nail or with your blade plate or whichever. And following that, we put the anterior plate.
Yeah.
After you have finished the main procedure, Then we put the anterior plate, usually about 2 screws above the fracture and 2 screws below the fracture. Your opinion, sir, Dr. Kulkarni, sir?
Do you need so many screws below or only?
I don't think so. I don't think so. Now in the recent cases which we are using, we are not, this was done initially, but now we have much reduced the number of screws.
Yeah, that's right.
Because as you said, it will become stiffer and the chances of breaking are.
Yeah.
We have reduced it, sir.
And also use of little longer plate is also now adopted.
Yes, sir. Yes, sir. Yes. Now we have started using longer.
So that is a lock plate, right? The one that
this is a lock plate. Yes. Yeah.
Good.
This has been our experience, but we have learned from this experience to put a longer plate and to do the, as sir said, this is what we have been doing.
Good.
Yeah. Thank you, sir. Shall I stop sharing?
Can you go back? Can you go back on that?
You want me to go back? Yeah.
Yeah.
Yes, Dr. Dhawan.
Yeah. One more.
Go back to the X-ray.
So now the question that we are kind of talking about is, so if you use an anterior plate,
yeah,
could you have got a DHS in this zone?
Okay, here.
Wrong
no?
DHS.
Here,
Yeah.
here. Yeah, could have got a DHS here, but then
with the only hold will be only one DHS at the top.
you will have only one DHS screw here.
Yeah, but
then you have
that would be equal to these 2 screws or 3 screws. Just wonder options.
Yeah.
This is nice.
So one, but only thing is how much of varus will get corrected with the DHS. We'll have to put it transverse like this, then bring it to the shaft and then correct it.
So are you saying that this correction came because of the plate?
No. Correction came because of
mechanical. You must have done an osteotomy or.
Yeah, we have done an osteotomy here. But what happened was once we put this screw and then fixed it, it was like a blade plate which you do for varus. It was off the shaft. Once we brought it to the shaft, then the varus got corrected.
Okay.
Maybe yes, with the DHS also you can correct it. But this was our experience with this particular plate, which in fact we did not want to do it because of its bad results. But we started using it in about 5 to 6 cases, and we will be able to present our series once we are using the newer locking plates. Is that okay? Any more questions? Hello?
Hello. Yeah, you are audible. Please continue.
Yeah. Any more questions? We can.
No.
I think in Assam they have a large series of using proximal femoral plates. We have listened to some of them there, where I think they purchased a large series of this and from Synthes, and they were forced to use these proximal femoral locking plates, and they have had mixed results. Some of them have not done well, some of them have done well. With the newer plates, the newer ones which Dr. Dhawan was describing.
I think there are some people who use it. Even nearby you also there is, I think somebody uses it with good results, but overall the failure rates are higher.
Failure rates are high. I totally agree. This was just on a trial basis.
It's a nice case. Yeah, nice.
So probably the proximal femoral plate works well when it's used as a part of the dual construct. Even here dual construct have been used.
Yeah.
Even if it's used along with a nail and a plate, even there it works well.
Yeah.
So probably it works well as a supporting role.
Yes. So a nail with a plate or 2 plates, it works well. Yes. I think that's a good option. Okay.
Sure, that's nice. Good.
Yeah. Can I?
Thank you. Can you please stop sharing your screen?
Yes, Abhijit. Yeah.
Yeah, thank you. The next case will be presented by Dr. Shankar Gurpat. Can you share your screen?
Am I audible?
Yeah.
Thank you. This is just to show our friends. Sometimes we get patients like this. So this is just a comment to Dr. Desai that yes, we also.
What is the weight of the patient? What is their weight?
When last weighed 145.
Oh.
So
Dr. Shankar, I have nailed femoral shaft in 125, and again there we nailed in lateral.
Sir, the trick sometimes is not to bother about the length of the incision. So this particular lady was so obese that we actually had to make an incision to pass the jig subcutaneous.
Yes.
Okay.
You might need 2 incisions, perhaps. Yeah, no.
No, it was one large incision.
Okay.
To I don't know if my pointer is coming there, but we needed a larger incision here to pass the jig subcutaneous, and then under C-arm figure out where the hole is to make the appropriate entry to get through the jig. So you had, a series of interesting incisions.
Right.
This is just to remind all of us that sometimes we do get massive patients, and for those of us who are not very, very conversant with the lateral position, don't worry, we can still sort it out on the fracture table.
Probably you need special size jigs.
Well, actually, first of all, you need a table that's willing to handle this.
Exactly.
So our standard routine fracture tables will give trouble. By God's grace and by the love of our management, we've got a Mackay table which has been with us now for over a decade. So that worked and it's done very well. Now, the case that I'd like to share with you is actually something which has been now on our follow-up for approaching many, many years. He was a 42-year-old, 90 kg smoker at presentation. This was the initial X-ray that he has with him. The initial X-ray of the fracture is not there with him. Okay. This is the first X-ray that he had with us, with him, and he has come to us roughly about 1 year after all these things have happened. So this is, as usual, something that has been gifted along. So this is the first X-ray that he's got. We noticed that obviously the surgeon has had quite a lot of trouble. A short nail in somebody who's actually not very tall. So first of all, that is an interesting problem for us to worry about. Why were they forced to opt for a short nail? Second is a circulage wire in the middle of the femur. Again, not something that one would do on a routine basis. So we went through the next set of X-rays. So at the 3-month check X-ray was the first time that there was a discovery of a neck of femur fracture in this person. Okay, there is no mention in his discharge summary that he had a neck of femur fracture on day 1.
But was he walking on this nail?
No, he was not walking. He continued to smoke, but he was walking non-weight bearing because he was told by his surgeon that please don't walk on this. There's a lot of shattering in your fracture. Please don't walk on it, which is fair enough. Now at 3 months, this is the situation. So the surgeon said that.
So Dr. Shankar, was it done on a fracture table in this case?
I don't know, sir.
Okay.
This was not my. This didn't come to me at this point in time. I'll tell you when it came to me.
So,
Dr. Dhawan is not going to leave me with the fracture table.
Can I have a comment on this?
Yes, sir.
Yes, sir.
See, this is a nail wrongly used. This is not the nail for intertrochanteric entry point. This is not the nail for this is the piriformis entry point is needed, and that is one of the reasons why this has failed. Reduction was not proper, probably, and it is very difficult to say that he had a neck femur at that time. Probably may not. The case I showed you, the last case, there was a similar case, exactly similar case. The nail, similar type of nail was used, and 1 year he was walking, and that is why there was a stress fracture at the neck of the femur. Secondary to non-union and patient walking on it, and probably this is a stress fracture.
I think the other thing is that the circulage is also missed the main fragment.
Possible. So anyway, the surgeon said that this needs to be redone, and justifiably so. So took the patient back into OT and did this.
Okay.
Okay.
Again, since I'm not the surgeon, and I mean, this is after learning experience, any comments, criticality from the moderators and seniors?
So how long is below this? This just finished 2 more screws?
Well, that's the
okay.
length.
That's
Okay,
a big-
so it's
big
not,
inci-
and the surgeon was kind enough to,
Put a
it's
small-
obviously somebody has thought about it and done some work on this surgery.
Go back, go back. Yes, I think the suboptimal proximal fixation, that's one. Suboptimal screw placement. I think the reduction of the neck itself also is not what would be ideal for this. So I think you're probably going to land up with a loss of fixation very soon with that situation. Plus the biology over here is all knocked off. So as I said, too many
Failure
screws.
of the implant.
So in our mind, there were a couple of problems in this zone. First of all, an isolated DHS for a vertical oblique fracture is begging for trouble.
Yeah.
Without valgization of the fracture zone. If at all somebody is willing to put in a DHS as the primary implant for a vertical oblique, it must be protected with something else. And the something else would typically be at least an anti-rotation screw to provide a tension band superiorly, because that is the actual way that the anti-rotation screw works. Provided it is perfectly parallel, it provides a tension band proximal and therefore shuts down the tendency for further malrotation there for us. Anyway, that discussion apart, here this is begging for trouble.
Yeah.
And this is also in varus. I mean, at the end of the day, this is not a straight line. And the tip of the GT should have been here to get the proximal femur in the correct valgus. Now,
can I comment here?
Yes, sir.
See, in such cases, non-union of the neck femur and a non-union of the shaft, the non-union should be treated with a valgus osteotomy, DHS, with a long DHS plate, and retrograde nail. And the one or two screws of the DHS,
they have to interlock.
DHS should pass through the upper end of the retrograde nail.
Yes.
It is possible to do manipulate from below.
Yes.
And if you do that and a valgus osteotomy, and that has given good results with it. We have had some 3-4 cases, and we do valgus osteotomy first and then put this retrograde nail.
So the surgeon saw this at a further 3 months down the road and again took him back into OT and decided that he is going to do a reosteosynthesis with a non-vascularized fibula graft.
Oh, now it is very loose. The DHS is just doggling there, toggling such a big area.
Now,
infection.
I think infection.
Yes.
Yes.
So the pity is that at this point in time, the patient had not been worked up for infection, CRP, ESR, nothing was done. So, however, the fibula was put into place and he continued to do toe touch, weight bearing, partial weight bearing, and the gentleman continued to smoke. At this time, he came to us. So, obviously, with an elevated CRP, an elevated ESR, and a smoker, the things that had to be explained were, first of all, please stop smoking, otherwise we can't really treat you. That's first. And he said that he's tried to stop smoking and he was unable to do so. So we got him to meet our psych team for de-addiction program, and they did the appropriate things for that, which is they put him at that point in time temporarily on nicotine patch. Nicotine gum had just been introduced into India. He didn't like the nicotine gum, so he stayed with the nicotine patch for about 3 weeks and then eventually stopped. So once he came back from the de-addiction program, then we started our workup. Now, he had done enough of shopping before he came to us, and the infection issue was picked up, and he had been bombarded with IV antibiotics for about 3 weeks before coming to us. So obviously I wanted a clean slate. So no antibiotics while he was in this de-addiction program. Once he finished all that, we took him into OT, did a debridement cleaning up. Apologies for this rather bad quality X-ray. The technician blamed the patient and the patient blamed the technician, but at the end of the day, this is the X-ray we got. Basically cleaned up everything, and then IV antibiotics based on cultures. Thankfully, he did not grow an MRSA. He grew a CONS, coagulase negative staph. He was put on his teicoplanin for 6 weeks, and then he eventually CRP came down to within range at 8 weeks, 2 weeks of antibiotics. And then we went ahead with a plan for reosteosynthesis. Now in our mind...
Sorry, did you remove the fibular graft?
I could not.
Okay.
It's still here. There is some shadow there. That's why I apologize for the poor X-ray, because I mean, it was just one of those things. So the options in front of us, if we use this to start planning out what we had to do, or this for starting what we had to do, one is we've got to deal with this hole over here, which means the only good bone we've got is basically here on the medial aspect and the inferior aspect of the head. There is definitely some amount of collapse that is happening or has already happened at the neck. So coxa brava is done. There is nothing that we can do about it right now. If we try to adjust anything here, I might have a further non-union to deal with on the trochanteric side. That is my anxiety. The issue of an intramedullary device, I'm very skeptical because of what we've got to deal with in the proximal femur. So my go-to would have still been an extramedullary plate-based option. So we went for, since the only bone that is decent was inferior and medial, we opted for a fixation base using a DCS on the proximal femur. I can see many people cringing at this, but let's accept certain facts that when the bone that is available to us is below in the lower half of the head, this still is a decent option for us as a bailout option. Again, I would stress that in today's world, we should not be using a DCS in the proximal femur as our first choice. This is honestly one of those situations where I don't have bridges to use. Now, the way that we went about this surgery was on a fracture table, sir. Dhaval, sir, on a fracture table.
Yes.
So the on traction, this was noticed to be fairly well reduced. This screw went in first. So this was on a guide wire, pre-drilled and everything kept ready. This screw went in first.
Okay.
And then the DHS, the lag screw was put into place, and then the plate landed up. Before the plate was finally seated, removed the screw and then reinserted the screw. So the idea being that this screw provided my compression throughout the whole thing. And then the rest of the plating went on. There were certain things that we were forced to accept. Coxa brava, and we tried to re-establish his alignment, net femoral alignment as best as we could. Now, there is a lot of bone graft that was used. We had access to allograft. So there's been a lot of allograft being used here. And of course, it's not a small incision. It's quite a big incision. You can see the staple lines here, some more over here. And this was done. Follow up at a few months. We started seeing some of these screws come loose and my BP started going up. His CRP stayed flat. It persistently stayed within the normal zone. So my biggest anxiety was whether the coagulase negative staph is going to raise its head again, and it did not. Now, another interesting thing, after this surgery, he still received only 3 doses of antibiotics and nothing else. Because if I tried anything else, my infectious disease team would have shot me down. So this was at about 4 months, and then the man disappeared and came back at 2 years with this. Now, I mean, he came in riding a motorbike. So he was otherwise perfectly fine, running around. He had regained his life, because in the intervening 1 year from the time of the fracture and his time to presenting to us with an infected proximal femur, he had lost his job. He was no longer able to even sit and work in the office. Now he was back at work. So at 2 years post-op, he basically came to give me a box of sweets and show me his X-ray that he had taken in his nearby X-ray clinic. And he said, "Take this, sir. This is for you. Take the sweets." And then he ran away again. So I don't know whether he continued to smoke or not. But anyway, the moral of the story was the take-homes were, number one, I think when we're dealing with an infected non-union in a smoker, the smoking must stop. That cannot continue if we are planning to hope for the fracture to heal. Second is that the debridement has to be merciless. There cannot be any non-alive tissue left alone there for us to have any nidus of infection waiting to come back at us. I appreciate what Dr. Uday Kumar said. That is, was I able to take out the fibula there or not? It was so well incorporated that whatever we did, we could not identify it as a separate thingy and pull it out. So sometimes it just becomes incorporated there. And on the X-ray, it looks like some cortical pieces, but in reality, it is just incorporated. And of course, trying to restore as much of the biomechanics as possible. I would definitely agree criticism on the fact that we have contributed to the coxa breva. But considering that we had to deal with a infected mess like this, and we eventually were able to achieve and give him a working functional hip with no obvious avian at whatever 2 years plus, I personally would be happy with this. Any comments and suggestions, sir?
Yeah, can I have some comments?
Definitely, sir. GSK, sir.
See, one thing, go back, can you go back to the, not, yeah.
Which one, sir?
Yeah, here.
Yes, sir.
You could have done a replacement with a long stem. That is one more possibility. Was
yes,
there?
Sir.
That replacement with a long stem. That is one option for this. Secondly, comments on this plating. It needs a longer plate, still longer plate, and you have an anterior plate also, probably. I would suggest we do in such cases dual plating and bone grafting, of course. But congratulations, you have done a very, very bad case into a very good outcome.
Very, very good result.
Congratulations.
Thank you, sir. This is 14 holes Adler. So that's the longest that they'll ever give us in Bangalore.
Yeah.
Okay.
So
I think the only thing is you mentioned that the inferior part of the head has had the best bone. So I think the only other implant would have been a blade plate, which goes and holds the head, even though our experience is not so great.
Yeah. So a condylar blade plate was the other option. So we did keep a condylar blade plate as an option and all that. But then my headache with using a condylar blade plate is that you get a single shot at the cherry.
Yes. Technical problem.
So if now at least with a DCS system, once I get this lag screw to hold,
correct.
Okay, this particular time it went through the plate, but there are times where we put it off the plate, off plane, to catch hold of the calcar here or the inferior part of the neck and then bite into it and pull it into correction for us. Once that is done, then the rest of it becomes easy. And of course, when you are bashing in the condylar blade plate, I cannot do a tunneling plate like this because this was tunneled. So the incision is one large incision here, and the rest of it is tunneled, and all of this is a separate incision at the end. Now, I can very well, I don't have an argument as to why would one want to tunnel when we are dealing with a non-union or whatever else? Well, I think blood saved is blood saved, number one. Two is that less the soft tissue injury over here, at least on the lateral aspect, if we try and minimize the soft tissue injury, that's going to be good for us, especially in somebody who's been operated. This would be his 5th surgery in that area. And our bone grafting has occurred in a sort of oblique manner here, accessing here, and you can see all the bone graft there. And that bone graft is what saved my skin as far as the shaft goes. Now, the bone graft that was stuffed into the tunnels over here has eventually become bone over the next 2 years. Now, I don't have an explanation as to why these screws came loose. And again, I think Dr. Kumar has got quite a lot of experience with locked screws on the shaft side of DHS and DCS, isn't it, sir?
Yeah.
My experience has never been great with using locked screws on the shaft side of a DHS or a DCS. And I have been always worried about why would anyone want to use a locked screw on the shaft side when all the fixation anxiety is not on the shaft side, it is in the metaphyseal side. So why would we want a locked plate system here? Now, in fact, going the other way around, if we had locked screws here, I would believe that we would have had broken screws. For whatever reason, these screws loosened up. Whether it was
there was some micromotion going on with the use of cortical screws compared to lock screws.
So it permitted it to find its place of neutrality. And the bone graft that had been placed all over here, some of it probably melted away. Because if we see this X-ray here and this, there has been some melt away of that bone graft and whatever neocortex that he had. GSK sir and Dhaval sir, any comments on or thoughts on how you would look at things at this stage? Let us say 3-4 months after your surgery, you start seeing a couple of screws come loose and your CRP is plumb normal. What would you worry about?
Yeah. First thing, there is no infection.
No, CRP is plumb normal. Clinically, is perfectly good.
Now, the very important is whether the patient is going into non-union or whether he is going to united. That's the question, isn't it, at this stage?
Yes.
So, if there is infection is not there, then if the patient has got two things. One, if he is walking, if he has no pain at the site and there is no tenderness. If that clinically, if the patient is okay, then you must wait and watch. If the patient has got pain on walking, tenderness, then it is worthwhile revising.
So, following the same principles, we started seeing this nice ball of callus developing on the medial side.
Yeah.
Which is where we would expect it to be seen.
Yeah.
And we started seeing consolidation of graft in other areas as well. All of this consolidated nicely. And this fracture disappeared.
Yeah.
So therefore, our guess was that, like Dr. Kumar said, some graft had melted away and permitting the whole plate to come closer and closer to the bone. Therefore, some backing up of screws.
So one question.
A very good result.
One question.
Sir.
Can you go back? Go back.
Let me first get out of the Zoom. Yeah. Yes, sir.
Yeah. So
which one,
here,
sir?
over here. So this kind of union was there in the waiting time that the implant was removed and happening already? Or this
not
was,
really.
So you did not explore this area?
Which area?
The shaft area.
No. This is all grafted. So all of this is graft. So there's one, this is the equivalent of 4 TKR graft cuts and 2 heads.
In this area?
No. The head was mulched up and put into this. So 2 heads got mulched up and put into this.
This you said you bridged, no?
Yeah, but then this is, I still had access to it from here, and there's a lot of graft pushed into all of these crevices because all of it was like, it's like a broomstick that has been twisted. There are lots of empty spaces. So all of it had to be packed. and then only plate it up.
So what's probably worked in this is that you have got an alignment, a mechanical alignment is good over here.
Yeah.
I think the reason you did not get the plate fitted to the shaft was probably because of the tunneling. Because with the long plates, you need to have multiple levels of compression or a clamp to get. Otherwise, this plate will remain off center with the shaft.
Also, it contracts here and distally.
So if you contact
bridges.
distally first, then it will never contact here.
No.
That's what will happen with the long. When you slide or tunnel long plates, you'll end up in the middle having this phenomenon. Ideally, a cortical screws that's away from this is vulnerable to break. So therefore, if you had this situation, probably a lock plate would have been better option. If the plate's going to remain off from the bone. I think maybe you won because of two probably things. You got a very good alignment that's come through. You got adequate. The stability was good enough to hold on. So that's why I think the screws backed out, because probably with forces it was trying to kind of get the plate pull it off towards the shaft was probably aligning by itself. But nice case otherwise. Would you have thought of using like a reverse lace or something in this situation?
You mean a distal femur locking plate?
Yeah.
I've done that.
But this particular fracture.
No, not for this particular non-union. I've done that for a few other messes. And
and this gap, you had a lot of grafts, you're saying, in this full pack.
Yes.
This is
the shaft is packed. I told you about 3-4 TKR cuts and 2 heads. This is one of my single largest bone bank orders. Using this is the right side. So using a left side distal femur plate, flipping it up and putting it on top is something that we've done many times.
So
weird situations.
Now I come to my question to you again.
Which is again, A, off the book. B, it's not something that we should be talking about and saying we did a good job about it, because that's not really something that we should be proud of doing. That is, we should not be taking a left-sided plate and flipping it and putting it on top.
So my question again, talking about positioning is finally. So when you have to make a large reduction incision, I think there's no point putting this patient on a traction table, because
it's
open reduction. Yeah, that's what I'm saying. It was open. It wasn't.
Yeah, it's open. But I think the distinct advantage with a fracture table, at least with a good Mackay table, is that it does the job of a very strong, robust assistant who is not willing to leave the position that we have given it. So, pakad ke rakho means it just holds it there. But then again, it also means that it will not leave that position if you want to adjust it. So there is always a plus minus. You have to roll with the punches if you are using a fracture table. And I think those amongst us who use a fracture table for I use fracture tables for distal femur, for proximal tibia. Yes.
Okay.
So it's just a question of
I would certainly not use a fracture table.
Exactly. But I learned to do those surgeries without a fracture table. But then in private practice, when you don't have assistants and when you have gradually depreciating quality of assistants over a period of time, you come to trust your fracture table sometimes.
Just another query with this big gap over here. I was just wondering whether you would have shoved in a fibula from the top somewhere down here like that or no.
Sir, his fibula has already been shoved in somewhere.
I'm sure, but there is a thin one. So addition is just that you will get a good hold into this, and but he might not have more fibula left on his body.
So
nice case, nice learning.
Good. So may I make a quick comment?
Yes, sir.
Yeah.
Sure.
Yeah. Can you show the last slide, the last X-ray? No, the last X-ray. The last one. Yeah. Here, so probably if you see the distal fragment, it's going slightly into varus and the screws have loosened out. And probably this calcar screw in the proximal fragment, even that has broken. So probably after that screw broke and the distal screws got loosened up, probably the fracture docked. And that helps in union to a certain extent because you can see the change in alignment. And the second point is probably low-grade infection probably helps in union. Whereas high-grade union, high-grade infection retards union.
Agree with that, Dr. Uday Kumar.
Yeah.
Yeah.
Small bone-producing staph he had.
Staph.
Yes.
You've got a staff nurse and then you've got a staff to help you with the fracture heal.
So basically, surgeon treats and he cures.
I know. Lovely.
Good, very nice case. Good.
Thank you, sir.
So that brings us to the end of this Kale discussion session. Before we conclude, we have with us the Honorary Secretary of the Karnataka Orthopaedic Association, Dr. Bharat Raju. Over to you, Dr. Bharat Raju.
Good evening, sir. Respected seniors and dear friends. I bring the greetings from Karnataka Orthopaedic Associate Secretariat. At the outset, I would like to thank the West Zone of IOA for having taken up the initiative of organizing this trauma series. I would like to congratulate Dr. Ajit Shinde, Dr. Vikas Jain, and Dr. Ajit from Goa for taking up this initiative, and also the Honorary Secretary of IOA and also West Zone, Dr. Naveen Thakkar, and our IOA President, Dr. Ramesh sir. Karnataka Orthopaedic Association has always been open to these kind of initiatives, and we are very happy that the West Zone of Iowa has selected us for this very first joint webinar. Thank you, sir. And I also thank all the faculty from the West Zone of IOA and Karnataka Orthopaedic Association for conducting this useful webinar. And thank you all. Hope we'll have another useful seminar like this very soon. Thank you all. Good night.
Thank you.
Thank you very much, Professor Kulkarni, sir, Dr. Dhaval. Thank you very much. Nice case, Dr. Shankar. And Abhijit, congrats to you for moderating it so nicely.
Thank you. Very nice cases. Very nice cases.
Very nice cases.
Nice presentations and very nice discussion. I learned
a lot.
Sir. Yes, sir. I learned a lot from this webinar. Thank you.
Yeah. Thank you. Thank you, everyone. Thank you, Dr. Abhijit. Thank you.
Dr. G S Kulkarni, sir, the past president of IOA, Dr. Dhaval Desai, sir, the chairman of AO Trauma India, and all the esteemed faculty from the Karnataka Orthopaedic Association. We look forward to have some more seminars in the near future, and do log in for this entire month where we will be having a West Zone IOA trauma webinars going on. The topic for the next Sunday, which is 10th of July 2022, will be open injuries, management of open injuries, while the topic for the 17th of July, which is again a Sunday, would be injuries around the shoulder joint. So hope to see you soon and have a great week ahead. Bye-bye. Good night.
Thank you. Thank you, everyone.
Thank you. Thank you.
Thank you. Bye-bye.